Now it's my pleasure to introduce Dr. Ahmed Farid from Suez Canal University. Dr. Ahmed will going to talk about the STEP trial. Dr. Ahmed.
Good morning, everybody. First of all, I'd like to express my deep thanks for Professor Mohammed Abdelghani for the kind invitation and for the Egyptian Society of Hypertension. My talk today will be about the STEP trial. The STEP stands for the Strategy of Blood Pressure Intervention in Elderly Hypertensive Patients. This is another trial about hypertension in elderly, like Dr. Shab had talked about the study that he talked about. The problem with the hypertension in the elderly that we have a lot of cutoff values. How low should you go? So if you are going with the clinical guidelines, you can see that American College of Physicians instruct you to stay below 150 millimeter mercury. The European guidelines say you should stick between 130 and 139. The American College of Cardiology should instruct even lower. You can go less than 130. And even the SPRINT trial that we just heard, it's going below 120. So how low should we go? And from this came the idea for the STEP trial, which was a prospective, multi-center, randomized controlled trial that included about 8,000 older hypertensive patients from China, including 42 centers in China, and included patients with the age from 60 to 80 years old of age. It defines the patient into two main groups: an intensive treatment group where you go with the systolic blood pressure from 110 millimeter mercury to below 130 millimeter mercury, versus the standard treatment where you go for the target of systolic blood pressure to 130 millimeter mercury to less than 150 millimeter mercury. And they excluded the patient with a cerebrovascular stroke, just like the SPRINT trial. What's new here, that they included the digital electronic sphygmomanometer during the office visit blood pressure measurements, and for the intervention group, they give the patients devices with, it's an Omron devices with electronic sphygmomanometer that is connected via Bluetooth to their mobile phones, and the patient was instructed to measure his blood pressure by these devices at least once a week, and these readings are sent electronically to the physician. So this is including more the electronic use of electronic devices in the management of hypertension. What's the primary outcome? It was a composite of cerebrovascular stroke, acute coronary syndrome, acute decompensated heart failure, coronary revascularization, incidence of atrial fibrillation, and death due to cardiovascular cause. So this is a composite of the primary endpoint. The secondary endpoints are each one of these in a separate fashion. How they included this? They do a screening for the patient, and they start randomizing in a one-to-one fashion, either to go with the intensive group or the standard group, and the planned follow-up was about 4 years. So we ended up by 4,200 patients to the intensive group and 4,200 patients into the standard group. So let's see the results of the trial. Regarding the baseline characteristic, it was equivalent between the both groups, but I'd like to highlight that the renal function was just the patient with abnormal renal function was 2.4% of the study population, which is very low. Regarding the control of blood pressure throughout the trial, we can see that both are going within the limits that I had defined. In the intensive group, the mean blood pressure was 126.7 millimeter mercury, and the standard group was 135.9 millimeter mercury. And this is the primary outcome of the study. We had seen that we have a reduction of about 26% of the primary outcome in the intensive group compared to the standard group, which was statistically significant, as the primary events occurred in 3.5% of the intensive group compared to 4.6% in the standard group. And also, the trial was stopped early in the 31st of December 2020 with a median follow-up of 3.3 years on the basis of clear cardiovascular benefits in the intensive treatment group at 2 consecutive time points. Our planned was to be for 4 years, but it was stopped early because of the benefit that had been noticed during the study. This is the secondary outcome. It's in a separate fashion. We can see a significant reduction all across all the secondary outcomes, including the stroke, the acute coronary syndrome, the acute heart failure, the major adverse cardiac events, and the mortality from cardiovascular causes. So the question that always comes to mind when you reduce the blood pressure of the patient, the safety and the occurrence of renal failure. So regarding the renal outcome, there was no significant difference between both arms, either in the reduction on the estimated glomerular filtration rate or in elevation of serum creatinine level, which is very impressive. And also, we can see that, making sense, that we had more hypotension occurring in the intervention arm compared to the standard arm, but this was not translated in clinically significant differences in dizziness, in syncope, or in fractures due to unsteadiness. So the conclusion of this study, that in older patients with hypertension, intensive treatment with systolic blood pressure target of 110 to less than 130 millimeter mercury resulted in lower incidence of cardiovascular event than standard treatment with a target of 130 to less than 150 millimeter mercury. And this had some implications that we should start to think about. That the STEP trial provide evidence to support the use of remote monitoring and the medication adjustment for managing the hypertension with the using of devices and the newer techniques. And this approach has the potential to improve the blood pressure control and reduce the risk of complication. And when you read this study, this is the only question that came to your mind. What we have learned from the STEP that we do not learn already from the SPRINT. As we had heard from the SPRINT, that already we have benefit in the cardiovascular outcome, but in the compensation for more events in the renal function. They share a lot of data, like they both work on elderly, they both excluded patient of the stroke, but the SPRINT excluded the patient of diabetes. Actually, in the STEP trial, they included the patient of diabetes, and they represent like 21% of the population. The targets for the blood pressure in the STEP was 110 to 130, while the SPRINT was below 120 millimeter mercury. Also note that the STEP trial had lower cardiovascular risk compared to the SPRINT trial. They both significantly reduced the cardiovascular deaths, but the SPRINT trial has increased incidence of renal failure with more than 30% reduction in estimated glomerular filtration rate. And also, the STEP trial had included patients with impaired kidney function at the baseline, just 2.4% compared to the SPRINT that included 28.3%. So these are the major differences between both trials. So to reach the conclusion of the STEP trial, that remote blood pressure monitoring lead to more adherence to treatment and better blood pressure control, the STEP study found that lower target, 110 to below 130, reduced the primary composite outcome by 26% compared to the standard treatment. And it's time to move the goal for blood pressure, and it's time to act. Thank you for your time.
Thank you, Dr. Ahmed, for this elegant and informative presentation. My question is, we have here the STEP trial was performed on Chinese patients.
Yes.
And the SPRINT was done on American patients.
Yes.
Do you think this apply on Egyptian patients? And if you have an elderly patient, which target you would choose, intensive or non-intensive? Because you don't have that about Egyptian patients. We're different ethnic background, different genetics, different lifestyle, everything is different.
Yes, this is a very important question. I think that ethnic variation makes a lot of difference regarding which antihypertensive should be used, how low should you go, and how they respond to these treatments. So I think we should not generalize the results of the STEP trial to all the population, but it gives you an idea that if you go to these levels with strict monitoring using some electronic devices, that may give you an idea or better control of the results you are getting at the end.
شكرا دكتورنا العزيز. The floor is open for the audience. دكتورنا العزيز تفضل.
It's my pleasure.
الترايل طبعا زي ما احنا عارفين the more lowering of blood pressure the more lowering of the hypertensive mediated organ damage او الديسيس. لكن this entity الجيرياتريك والاولد ايج هو what astonished me ان العيانين دول يعني tolerated the more aggressive reduction of blood pressure. ويمكن هو مطلع ان الريزلت ان no difference between الاجريسيف تريتمنت ما بين الستاندرد تريتمنت. عايز اعرف رايك، يعني انا مستغرب العيانين tolerated بالرغم ان احنا in real life العيان بتاعنا الجيرياتريك ما بيستحملش انك تعمله more reduction blood pressure.
That's a very good question to ياسر. هو الحقيقة it comes to me when I read the trial في 3 points in this trial should be kept in mind. أولاً الethnicity إن هم اشتغلوا على الشاينيز which is a little bit different. الحاجة الثانية إن هم استخدموا electronic devices في الفولو اب which is ده إلى حد ما prevent إن هم يجو more hypotensive less than 110 which I think this is make a lot of difference. لو احنا شفنا في السبرنت إن هم كانوا بيقولوا عايزين أقل من 120. If you go like 105 that's okay for them. لكن هنا هم ما كانوش عايزين ينزلوا تحت ال 110. I think this prevents a lot of deterioration of kidney function. الحاجة الثالثة التايب اوف medications used. هم هنا most of the study استخدموا الأولميسرتان والأملوديبين والهيدروكلوروسايزايد. دول كانوا في most of the patients. ما استخدموش حاجات فرايتيز ثانية، ما استخدموش الفالزرتان، ما استخدموش الحاجات الثانية. I think this may have also an impact. ما اقدرش احدد ولكن ده كان اكتر حاجة من الميديكيشنز اللي استخدموها هم الثلاثة دول.
دكتور أحمد تفضل دكتور. Just may you explore more. Was there any effort to categorize these populations? We are talking about 60 to 80. This is not a homogeneous total group.
Yes.
I'm 60. Okay. I'll be different than myself at age of 70 and more towards 80 as well.
Yes.
This is number one.
Yes.
Number two, if we are reflecting it to the real practice, our usual real practice is approaching to 130 home blood pressure measurement. But we are not approaching 110, more likely, isn't it?
Yes.
So putting 110 to 130 as a group might be very wide, and it might be worth to categorize them into those approaching 110, those who are around 130, and those who are around 150. Was there any effort to do that?
Yes, I think this is absolutely very important. You should not put all this age in one bucket. The 60 is not like an 80. I totally agree with this. And also, you need to subcategorize. I think if they can separate this, so 120 to 110 and 120 to 130.
So we need to put that in mind before reflecting it to the practice, because it doesn't go homogeneously with our real life practice. Shukran.
Absolutely.
Just one more comment on what Dr. Yasser said about lowering blood pressure in Egyptian patient old age. We got to keep in mind that their elderly are totally different from our elderly. Their elderly are active, having full life, going to recreation facilities and doing physical exercise. Unfortunately, our are totally different. This is one thing. And I think the target should be individualized according to the patient in front of you, because some can tolerate lower blood pressure, others cannot. So I think it could be tailored for each patient at each.
For his comment, this might be reflected if we could know the diastolic blood pressure variance in these two groups, which usually, for those who are more active persons, we usually having better diastolic blood pressure in terms of less arteriosclerosis. Okay, and this might be a post hoc analysis if they didn't do the job yet.
Yes, yes.
Thank you, Dr. Ahmed, for your presentation. But I'm quite confused. Yani, do you have a recommendation to go as a target in elderly systolic blood pressure below 130?
According to this trial, yes.
ده بعكس كل الجايدلاينز. كل الجايدلاينز تقول لك التارجت بتاعك يختلف لما بتتكلم على حد كبير في السن. واظن الانترناشونال سوسايتي اوف هايبرتنشن فرقت بين below and above 65. لما نتكلم على above 65 التارجت بتاعنا لازم يبقى below 140 not 130. اليوروبيان جايد لاينز الامريكان جايد لاينز كلنا قالت لنا لا الالدرلي لهم وضع مختلف. وما ننساش كمان ان انا عندي جي كيرف، يعني كل ما السيستوليك بينزل هيبقى عندي فرصه ان المايوكاردال انفاركشن يزيد. don't reduce diastolic blood pressure below 60 ولا السيستوليك below 120. الستيب قالت حاجات مختلفه.
الستيب قالت حاجات مختلفه، ولكن الستيب ناقصها حاجات كتير علشان نقدر نجنرالايز الريزلت دي. واحده منهم طبعا الاثينيسيتي، الحاجه الثانيه اللونج تيرم فول اب. احنا شفنا في السبرنت ترايل لما عملنا لونج تيرم فول اب علشان نشوف الديمنشيا ونشوف الكوجنيتيف فانكشن ديتيريوريشن، لقينا ان في ديفرنس. I think this should change how we should do. هي just ان هي raising the alert ان احنا نقدر نجو lower without deteriorating of the kidney function او without increasing the side effects provided ان ده monitored. انا برضو حابب ااكد ان الستep مأكده ان لازم القصه دي to be monitored regularly monitored.
دكتور احمد بس جاست انا يعني تكمله لكلام استاذنا دكتور محمد عبد الغني، كنت عايز اسال حضرتك سؤال بيرسونال بقى.
اتفضل.
based على this very elegant presentation، حضرتك جالك عيان كده what will be your strategy؟ يعني لو عندك عيان elderly حضرتك هتعمل ايه بعد ما حضرتك قلت لنا المحاضره دي؟
I'm still
I'm
convinced.
still saying برضه زي ما دكتور عمرو قال Egyptian طبعا مش
ده صحيح.
مش
still انا ما يعني I don't imply this in practice but I go below 130. below 130 لكن not below 120.
يعني هو حضرتك الدسكشن طبعا جميله يا احمد، بس احنا لازم نحط في بالنا ان احنا محتاجين ستاديز في مصر فور ذيس جروب، لان البرسوناليتي بتختلف والاكتيفيتي بتختلف، وفي حته حضرتك مهمه جدا الفرايورتي بتاع العيان. يعني ممكن يجي لك عيان عنده 80 سنه وفيري فيري هيلثي وما عندوش ريسك فاكتورز، اعمل معاه اللي انت عايزه. انما لما يكون عيان فرايل وعنده مالتيبل ريسك فاكتورز، انت هتخاف من انك انت الريدكشن اوف ذيس بلاد بريشر يدخل عيان فرينا وذس از فيري كومن. فالموضوع محتاج بالنسبه لمصر محتاج ان احنا نعمل ستاديز سبيسيفيكالي فور اور بوبيوليشن. شكرا يا احمد.